We'll go ahead with the next talk. Is given by Dr. Anurag Mishra. Dr. Anurag is going to talk on the charisma of advanced monofocal lenses. Dr. Anurag, please.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Jagannath. Now, this next segment is basically going to be the advanced technology monofocal IOL, named as Clarion, coming in from the Alcon laboratories. And when we discuss about any IOL, there are several segments of it that we dissect and analyze and discuss. Those elements would be essentially the material. In terms of design, how good it is to the bag and how effectively does it prevent the incidence of posterior capsular opacification. And since we have moved largely onto the toric platforms and across platforms and across variants, how does it do in terms of the stability inside the bag? So as the picture is quite clearly evident, the Clarion does look more clearer than the Acrosoft over the ages. If you do not take into account the unfortunate incidence of IOL opacification, the thing that actually mars the optical clarity of any IOL with advancing age as it spends time inside the eye are two. One is the glistenings and the second is the subsurface nano glistenings. To test that, the Clarion IOLs were submerged in a bath of BSS and kept there for 80 days at 91 degrees Celsius, which actually mimicked 10 years of aging of the IOL inside the aqueous bath. And what we found was both SSNGs and the glistenings were significantly lower. They were comparable to any other IOL which did not have glistenings and was there in the market for a substantial period of time. So these are the pictures, electron microscope modified and magnified to just look at the slits and find out that the SSNGs and the glistening scores were minimal. The PCO, how it behaves inside the capsule, is the PCO rates are already low with the Acrosoft platform. It's also low with the Clarion. Apart from the material, apart from the design, what also scores is the material. This is a square edge design, and the proprietary design that the Clarion has at the edge is it's not very sharp. It's not a 90 degrees square edge. It does have a little bit of convexity on the posterior surface, which fits with the concavity that the posterior capsule leaves behind. And apart from that, there is a stable force haptic, which also takes in the axial compression that happens with the back contracture with a period of time. There's a kink at the optic haptic junction which actually takes in that stress. It has a spring action inbuilt. The haptics fold, but the optic does not come forward. So for the toric lovers, this is the news that the fibronectin binding, which Acrosoft platform was so proud of having, the Clarion has it less than the Acrosoft, of course, because the hydrophilicity has increased. The water content has increased from 0.5 to 1.5. But to call any material hydrophilic, the water content has to be well above 5%. So it's still way below that, but the water content has wee bit increased to take care of glistenings, to take care of SSNGs, but the fibronectin binding is still comparable with the Acrosoft. Now, coming to, these are the attributes of the IOL. The testimonials from me, we have already crossed more than 500 Clarion torics. I'm not counting the non-torics into this. And we have implanted all variants of that. 2 of my patients had an unfortunate residual of 0.5, but that was basically due to biometric error, and none of them had residual cylinders. But the question here is, it's not competing with the other brands. What it is competing big time is with its predecessor. Questions are asked, why did we need another material when we were already very happy with the Acrosoft material? So that comparison comes in very handy. Now herein, I'm trying to implant the Acrosoft here. When it comes out of the cartridge, as you can see, it comes out as a rigid cylinder. We just saw Shell's first case, how it shot out. Now, after going into the bag, as I'm trying to still unfold it and settle it inside the bag, the Clarion on the other side is pushed in. It opens up as it goes in. So it doesn't give you that cylinder kind of a fill. And as the Acrosoft is still getting unfolded and getting settled in the bag, the Clarion has already done it. So this is what we gain. This is very slight resistance while it goes out. I'm not saying that the Acrosoft's resistance was too much and not something that we cannot handle, but I'm just saying that this is even better with the Clarion platform. Now, this was one patient, real-time experience, real-life experience. In the left eye, Acrosoft was implanted way back. In the right eye, we have implanted Clarion, and I subjected him to a few evaluations before the eye trace. This is the MTF curve. As you can see, the critical square is right here. This is the internal plane. At 10 cycles of degree, it's doing pretty well at 0.473, which is pretty good by industry standards. But when you look at the Clarion eye, it's even better. It's almost double. I'm not saying that the difference is this much in every case, but there is a difference, and the MTF curve always does better with the Clarion platform. The same patient with the VSOTF curve, which is actually plotted taking into account both MTF and point spread function, and we know that they are counter-regulatory to one another. As you can see, the peak of the curve, the 100% curve reaches a 0.8, and look at the sharpness at which it rises up. This is the right eye. The left eye is not doing bad, the acris of eye, but still the peak is well below 8.8 and it reaches up to 0.7. Now this difference can be substantial. The depth of focus curve, combined eyes, what is the other question, as it's proposed that the Clarion does give a functional intermediate vision. You can look at the depth of focus curve here, which is all of length and half of width. It's a little tricky to explain that to you, but the depth of focus that is coming from both Actisoft and Clarion are in the range of 1. So it's not that the Clarion is new to this. The Actisoft was already providing some amount of intermediate vision. We just were too blind and we were negligent not to look at this. Now I'll end up with this real-time patient testimonial. This was one patient who was very highly myopic. As you can see, the IL power is 18.5 with a very high cylinder requirement as well, T6 in one eye, T7 in the other. I'll just show the discharge summary of the other eye as well. I'm trying to ask the patient to read letters at an intermediate distance of 50 centimeters and look at the patient's response. Do we have sound? Yes. T6 and T8, 16 and 18.
APORFDZ.
This is the N6 line.
81.
I move the chart and look at the phoropter screen. The addition I have given is +1. The patient just read N6 at 35, and he was equally comfortable when we shifted the chart from 35 to 45. So the range is a little more. If you ask me, share the experience with us, I would say that 70% of my patients require an addition of 1 to 1.25 for near, 1 to 1.5 for near. So that makes it a 1 diopters defocus, 1 to 1.25 diopters of defocus. About the rest 30%, a good 10% might need a full 2.25. I've never given a 2.5 add to any of the patients who have received a Clarion implant at least. But from 1.5 to 2.25 is where the rest 25%, 20 to 25% would remain. So it does impart a functional intermediate in quite a good majority of patients. And apart from that, the exceptional material clarity, very good dysfunctional lens index in the postoperative period, MTF and point spread functions also do pretty well, and the stability is spectacular. Thank you so much for your attention.
I think from your talk, I think, can it substitute for an EDOF lens?
No, sir, not quite, because EDOF...
Because the +1 correction is normally needed for an EDOF lens also, and what you have shown is that mostly the correction is only +1 for reading in these patients. So have you had a patient in which you have implanted the regular lens in one and the Clarion in the other and seen the difference?
Yes, I have. I've never done a monofocal tri combination, but I have done monofocal and VVT combination in the two eyes. And in fact, one of those patients is an unfortunate one who had a posterior polar cataract in one young patient. The other eye had very bad issues and a T9 requirement, so we could not implant a VVT. We had to switch on to Clarion monofocal toric, and that patient is doing very well. The difference, since you asked, sir, the VVT would give us an N6 at intermediate. The Clarion would never ever give us an N6 at intermediate. But with the near, a +1, as I said, a +1 to 1.5 is what 70% of the patients would require. With a VVT, I would say 95 to 99% would do very well with a +1 add. They'll never require more than that.
Thank you.
Pleasure.
I would agree with that. I mean, I think one of the things we learned from the multi-center trials...
So I can't hear you, sir.
Sorry, one of the things we learned from the multi-center trials looking at EDOFs versus a monofocal lens was the monofocal lens with the Acrosoft and actually got quite a bit of reading vision. And I find that toric Acrosofts are very good for monovision because you get the depth of both eyes almost like an EDOF without having to go down the route of an EDOF.
True. That's the reason why I said we were probably too ignorant to even see that in our patients.
Can we have the questions later?
Yes.
Sorry.